Good evening, doctors. My name is Rakesh Sonone. On the behalf of FDC and MedTalks, I welcome you all to yet another episode of 52 Weeks Diabetes Essential by Dr. Sanjay Karla. So, today's topic is hypoglycemia awareness training. And before going forward, I would like to announce last week quiz winners. They are as follows: Shantanu Kumar Bhattacharya from Kolkata, Devraj Bhai Dholaria from Surat, Ram Gopal from Udaipur, Sarfaraj Sheikh from Mumbai, Bharat Mitkola from Surat, Ravi Bhatt from Sirsi, Anand Purandare from Mumbai, Rakesh Bhargav from Delhi, Rinku Guptaji from Mumbai, Surjit Kalsi from Noida, Durgapada Dolai from Midnapur West, Jitendra Kumar Dayal Shah from Bayer, Ashwini Kumar from Kanpur, Pradeep Patra from Chhatrapur, Satish Kumar Jain from Bangalore, Rajiv Handa from Delhi, Ahmad Chipa from Barmer, Javed Ahmad from Lucknow, Machindranath Thakur from Kaiz, Hemant Mahajan from Buranpur, Sanjay Shah from Ahmedabad, Sanjeev Puri from Hoshiarpur, and Dr. Vilas Sonone from Asti. I would say congratulations to all quiz winners, and with this, I would like to hand over today's session to Dr. Sanjay Karla sir. Thank you.
Thank you, Rakesh, and good evening, everybody. It's always a pleasure being part of the FDC Diabetes Essentials. And these meetings that we have, these communications that we have, it makes us more aware of our subject, diabetes, and also more aware of so many other things in the world. Let's talk today about awareness then. And today we'll talk about hypoglycemia awareness. Now, when we speak of hypoglycemia awareness, we need to know what hypoglycemia is. We've all spoken about that. But the main focus will be on awareness and training. So let's see why this is important. When we manage diabetes, there can be many shortcomings on our part, and there can be many side effects. But one of the commonest side effects, especially with insulin and with sulfonylureas, is hypoglycemia. Hypoglycemia actually occurs, that is one statement. There is a fear of hypoglycemia, that is another statement. And if hypoglycemia occurs once in any patient, especially in an elderly patient, or if the hypo is severe, people become afraid and they become afraid of taking therapy. That has a negative impact on future management. Not only that, hypoglycemia is a mimic of seizure disorders. It is a mimic of transient ischemic attack. It can be a mimic of angina, of unstable angina, acute coronary syndrome. That's another challenge. Not only that, hypoglycemia can precipitate a seizure disorder. Not only is it a mimic, it can precipitate. It can also precipitate ischemia, cardiac ischemia. So therefore, we need to avoid hypoglycemia at all costs. But then managing diabetes is part and parcel of life, isn't it? And you have to take the risk. So, of course, the first thing is to use drugs which are safe. Use tablets, oral drugs which are safer, which cause less hypo. Use insulins which are safer, which cause less hypo. And at the same time, ensure that the patient follows a meal pattern, takes meals such that hypoglycemia risk is minimized. But even after all this, we need to be aware of the risk of hypo, and so we should train our patients. So, what is hypoglycemia awareness management or hypoglycemia awareness training? It's a theranostic tool, which means it is therapeutic and diagnostic. It is diagnostic because it helps us diagnose hypoglycemia before it occurs. So, patients who are at high risk should be taught how to and suspect anticipate and suspect hypoglycemia both. That's diagnostic. It is therapeutic also because when we train our patients in hypoglycemia perception and identification, we are giving them a therapy. This therapy gives them confidence and it allows for achievement of better results. So the first thing is to understand whom we should offer hypoglycemia awareness training to. You can have formal modules, but informal in the OPD. Any patient who is at high risk of hypoglycemia, patients on high dose sulfonylureas, patients on high dose intensive insulin therapy, these are at high risk. Patients with renal, hepatic, or gastrointestinal impairment, they are at high risk. Those who are elderly, those who have multiple comorbidities, multiple concomitant medication, they are at greater risk. Endocrine diseases, hypopituitarism, hypothyroidism, hypoadrenalism, these people will also be at high risk. Then people who have an erratic lifestyle, they are not quite uniform or not all that well behaved when it comes to taking regular meals, doing regular exercise, doing the same kind of meals, or taking the same kind of meals, or following the same kind of exercise every day. These people are also at high risk. So we must make them aware of hypoglycemia. Like we said, it is not only diagnostic but also therapeutic. And the aim is to train them in hypoglycemia perception, identification, and management. So the first step is to explain the pathophysiology of hypoglycemia. So I might tell my patient, yes, we are giving you such and such a drug, and it is to be matched with your meals. In case there is a mismatch between meal and medicine, there may be hypo because insulin levels will go up. And if there's not enough sugar or glucose or calories in the body, then we can get in trouble. What are the troubles we can get in? These are the symptoms. So let's explain the symptoms to you. And it's important to manage these so that we can optimize our health. So hypoglycemia identification tools, one that is used abroad is Stanford Hypoglycemia Questionnaire. This was developed in Spanish and then later on converted into English. And this also talks about culture-bound symptoms. Here in South Asia, I would commend the Hypoglycemia Awareness Question, HUC, HAQ HUC, that is our right. It's a very simple structured tool. We have four questions that we ask. Four relate to adrenergic symptoms, four relate to neuroglycopenia, and two relate to nocturnal hypoglycemia, and then there are two more. All questions relate to the preceding week, and they specify unusual episodes in the stem of the question. This questionnaire serves multiple purposes. First of all, it improves the quality of our history taking. Secondly, it improves our communication with the patient. It's a checklist which helps us screen not only for hypoglycemia but for other complications as well, like neuropathy, autonomic neuropathy. And once you begin this conversation, it works as a springboard to identify other comorbid conditions as well, which may be hot flashes, acute panic attack, transient ischemic attack. So, multiple diagnoses come out of this. Let's look at the questions. We have the following questions, and in all of them, we will ask, in the past 1 week, have you experienced unusual episodes of the following? So, feeling of uneasiness. Have you ever felt uneasy? Profuse sweating, not explained by the ambient temperature. So, profuse sweating even during winter. Trembling or shaking or palpitations. These are all autonomic symptoms, adrenergic symptoms. Then, uncontrollable hunger, difficulty in thinking, concentrating, speaking, seeing, hearing, moving, performing daily activities of life. Difficulty in thinking or in working, in thought or in action. Altered movements or seizures, or extreme weakness, giddiness, dizziness, or maybe loss of consciousness or even fainting. All these are neuroglycopenic symptoms. So, difficulty in thinking or working, altered movements, extreme weakness or dizziness, and loss of consciousness or fainting. These are the neuroglycopenic symptoms that we have. Two symptoms relate to nocturnal hypoglycemia: disturbed sleep or nightmares, so poor quality of sleep or nightmares, and also early morning headache in the morning. These are symptoms of nocturnal hypoglycemia. And the 12th one is documented reliable low glucose values. So, glucose values on the meter. That's the last question. So, have you ever seen actually low glucose values? When we ask these questions, and you don't need to sort of think of them as 12 separate questions, just classify them as adrenergic as well as neuroglycopenic symptoms. This allows us to understand what the patient is going through. The patient feels that, yes, the doctor is worried about my health, my well-being, and then you can titrate the doses of insulin or sulfonylureas. It also facilitates patient empowerment because, like in my OPD, many times I use sulfonylureas. The squad tablets, We can always tell the patient to break the tablet in half if they suspect or anticipate or experience. If they suspect, anticipate, or experience hypoglycemia, any of these symptoms, they can reduce the tablet to half. Sometimes the tablet is not scored, so maybe metformin plus glimepiride 2 milligram. We tell them keep an extra strip of 1 milligram 1 milligram glimepiride plus 500 metformin with you, and you might shift to that in case you feel that there may be hypo. So this is the questionnaire. Now let's rephrase what we have talked about so far. Hypoglycemia is a common occurrence in the diabetes clinic. We have to be aware of it. We have to make our patient aware of it, especially high risk patients. These are the ones who are on high dose sulfonylurea or on insulin, intensive insulin, and also the ones with medical conditions, comorbid conditions, and multiple concomitant therapy. Also, those with an uh, unpredictable lifestyle. All these should be offered hypoglycemia awareness training in the OPD. The aim of hypoglycemia awareness training is to ensure hypoglycemia perception and identification. So we need to teach them the pathophysiology and the symptoms. They need to know how to identify hypo, and then they should know how to manage it and prevent it. So this is a part of holistic health. We'll come to autonomic optimization shortly. But what all these things tell us is that these should become part and parcel of our OPD practice, of our language in the OPD. Hypoglycemia awareness tool should be integrated in whatever we do in the OPD. So this is really important. Another thing to know is that when you're speaking about these symptoms, the verbiage of the patient is very important. See, verbiage means the words that the patient presents with. Let me give an example from my state. In Hindi, someone may say, "टीके से गर्मी हो गई." I felt hot with the injection. That is profuse sweating. And in Punjabi, the same patient may say, "टीका लाया ते ठंडी तरेली पै गई." I had cold sweats. So see, if you understand the verbiage of the patient, one lady is saying hot, heat. The other one is saying cold, cold sweats. Both exactly opposite words, exactly 180-degree opposite verbiage, but the message is the same. So be aware of the local verbiage. Example is someone coming and saying susti, sustu. What does that mean in Kannada or in Malayalam? Does it mean hypoglycemia? Does it mean malaria, fever? What does it mean? So these are questions. Let's look at verbiage from across the country. Now, coming back to our questions, any positive response should prompt us to tell the patient to modify diet, physical activity, or drug dosage. If the answer to HAQ question is positive, the higher the number, increase the frequency of glucose monitoring, increase the frequency of consultation with yourself. Also, at the bare minimum, do suggest for someone who has suddenly gone into hypoglycemia, kidney function test, liver function test, and TSH. Kidney function, liver function, and TSH. The commonest things in our OPD would be a high thyroid, a high TSH, and a high blood urea creatinine. These are high frequency of hypoglycemia can be a marker of uh, development of hypothyroidism or renal impairment. You can share this with your diabetes educators, even with your receptionist and physician assistant, so they can ask these questions to the patients. And you can red flag the patients who need more attention from you. So that's what hypoglycemia awareness training is. But hypoglycemia awareness training is not just about asking questions. It's also about examining the patient. If you have a patient with autonomic neuropathy, then the chances of hypoglycemia unawareness are higher. So how do you assess for autonomic neuropathy? Autonomic neuropathy can be at the level of the pupils, the skin, that is the pseudomotor system, the cardiac system, the genitourinary and gastrointestinal tract. So 5 aspects of autonomic nervous system. Out of these, for sweat, genitourinary, and gastrointestinal, you just have to ask the important symptoms. Take a history. But for cardiac autonomic neuropathy, it would be a good idea to look for the signs as well. So look for loss of heart rate variability. Parasympathetic dysfunction usually precedes sympathetic dysfunction in diabetic autonomic neuropathy, which means that patient may present with tachycardia. So loss of heart rate variability is the first, followed by resting tachycardia. And if you see these, then that means you have to screen more carefully for autonomic impairment and also um, for hypoglycemia unawareness. And the treatment of hypoglycemia unawareness is, first of all, hypoglycemia awareness training. Secondly, go very soft. Use insulin analogs, which are safer to use in low dose. Avoid use of sulfonylureas. One way that we can use in hypoglycemia awareness training is to help our patients is autonomic hygiene. So you make them understand what their autonomic nervous system is like. Our colleagues in alternative medicine use the word meditation or mindfulness for it. It's the same thing. So let the patient be mindful. Let the patient understand what his or her parasympathetic and sympathetic symptoms are like. The moment sympathetic symptoms kick into play, it means it is possible there is hypoglycemia. For many of our patients, they will not understand sympathetic, parasympathetic, but they will understand the Sanskrit words Rajsik, Tamsik, and Satvik. Autonomic hygiene or autonomic balance is a state of Satvikta, equipoise, equanimity. Tamsikta, tamas, is parasympathetic. And Rajsikta or Rajsik behavior, that is hyperadrenergic. So if your patient says, suddenly I began to feel hyperadrenergic, I began to feel angry, irritated, more aggressive, that is a sign of hypoglycemia. The word aggressive is important. It doesn't have to be physical aggressiveness. It can be mental aggressiveness as also. Mental aggressiveness means patient says, yeah, I'm otherwise very calm, but around 1:30 or 2 o'clock, I don't know what happens to me. I just begin to get angry. It's possible the patient has got neuroglycopenia. And hypoglycemia awareness training will help you pick that up as well. Actually, this happens to me in my OPD too. So there is something known as hypoglycemia aggression hypothesis. This was propounded by not by a doctor or an endocrinologist, it was propounded by an anthropologist who was working in South America. What he found out was that there was one particular Indian tribe that was always hostile to outsiders. And all the tribes around that, they were quite open to communicating with outsiders. So he checked glucose in all those tribesmen and women, and he found out that their glucose levels were low. So he propounded the hypoglycemia aggression hypothesis, that people who are hypoglycemic are aggressive. Whether it is true for that Indian tribe or not, I do not know. But in my OPD, I find that around 1:30, I also become a bit irritated and short-tempered, and our patients also become short-tempered because it's been quite some time since they had breakfast, and they become aggressive. So the trick is to have a cup of tea, have a biscuit or so before you see your patients after 12 noon. And the other trick is to be a bit fast so that patients don't have to wait too long. This concept of autonomic balance or autonomic hygiene is quite practical. It's very pragmatic. You can use it at individual level with yourself. You can use it in your OPD at a larger level. Make sure that all your staff get a snack break. Same in schools. Children get breaks in between. And also change maybe culinary practices or sports. Try to see when people eat food, when people exercise, see that autonomic hygiene is maintained. Explain this to the patient as well, and if you are able to teach them how to pick up their hypersympathetic hyperadrenergic signs, you will be able to prevent hypoglycemia. It's also important to remember that the autonomic nervous system is a bridge between the nervous system and the endocrine system. The autonomic nervous system works on catecholamines, adrenaline, noradrenaline. So these are hormones. And the parasympathetic nervous system or the vagal system, that is part of the nervous built of the body. Both communicate with each other, both communicate with the outside world. And if you can fix this bridge, the nervous and endocrine system bridge, and also the psychological bridge along with that, you can actually improve not only autonomic health, but overall nervous health and overall diabetes health. So it would be a good idea to begin speaking with our patients from tomorrow onwards about hypoglycemia awareness training. If you wish, we can do a formal kind of a formal workup on this anytime during FDC Diabetes Essentials if you feel so. We can get experts who will talk to us about how to be aware of our symptoms. You don't have to meditate for that. You just have to be aware of what sympathetic and what parasympathetic symptoms are in you. We have to be aware of how to change the diet, the exercise, the pharmacology, and also some yogic postures which help in autonomic balancing. About exercise, there is a lot of discussion about when to exercise, daytime, nighttime, whatever time suits the patient. But if you have aggressive exercise at night, very intensive exercise, that actually will lead to tachycardia. It will lead to hyperadrenergism, and sleep may be disturbed. So, one of the reasons of disturbed sleep may be aggressive or intensive exercise late night. So, avoid that. Other reasons will be exposure to caffeine, exposure to alcohol, exposure to hyperadrenergic um, stimuli, such as maybe watching a horror film at night. So, all these should also be avoided during the night time. And all these will also help in managing, not only in managing autonomic balance, but also improving long term cardiovascular and metabolic health. So, we've spoken about hypoglycemia awareness training today, but let's look at our first quiz question. Which of the following medications can increase the risk of hypoglycemia in people with diabetes? Which medication increases the risk of hypo? Is it insulin, antibiotics, antidepressants, or painkillers? So, question one: which medication can lead to hypoglycemia? Insulin, antibiotics, antidepressant, or painkillers? Our second question, we didn't mention this, but we all should know, what is the recommended glucose level for treating hypoglycemia? So, what is the cutoff for minor hyperglycemia? Is it below 120 nanogram per ml? That's the question. 120 nanogram per ml. B, is it 180 milligram per deciliter? C, is it below 70 milligram per deciliter? Or D, below 200 milligram per deciliter? So let's see the answer to this. What is the recommended glucose level where we should manage hypoglycemia? Below 120 nanogram per ml, below 180, below 70, or below 200 milligram per deciliter? With these two questions, let's take questions from the house. And I was not available last week to answer questions live. I apologize for that. Thank you everyone for being with us. So Dr. Mukesh Makrolia says, which is safer in chronic liver disease? Yes, linagliptin is safer than sitagliptin. That's the safest in both hepatic as well as renal impairment. Linagliptin has a dual excretion pathway. So if the liver is not working, the kidney will excrete. If the kidney is not working, the liver will be able to manage the drug. It's a good idea to avoid fibrates and saroglitazars in high triglyceride. If the triglycerides are very high, the treatment of choice would be, of course, lifestyle modification. Insulin will reduce triglycerides markedly. If the TG is more than 500, go ahead with fibrates, fenofibrate 160. Fibrates will not improve CV outcome, but they will bring down the triglycerides. And there are studies which show that fenofibrate reduces the progression of neuropathy and also retinopathy. Fenofibrate is approved in Australia for secondary prevention of retinopathy. Saroglitazar is approved in India for high triglycerides, but long-term data is not there. So you can bring the number down, it will be window dressing, but there is no long-term data showing improvement in CV outcomes. I use fibrates, and many times we have patients with high DG who ask for a therapy or who are not willing to tolerate or not willing to accept high dose of statins. Then I use fish oil capsules, actually, omega 3, omega 6 capsules. Use any brand um, with adequate dosage, and you will find that that will also work. Warm good evening to Dr. Vinay Desai, who shares a case of a 55-year-old lady with white color urine or chyluria. Commonest reason would be urine infection. We can do a culture and give an antifungal course maybe for 7 days before testing further. So we can give an antifungal course, maybe Zocon, fluconazole 150 milligram OD for 7 days. Also, get a urine routine and maybe urine culture. So gabapentin, Dr. Nitin, will not help in numbness. Gabapentin will help in positive symptoms. Positive symptoms means like pain, burning, lancinating pain, discomfort. For numbness, we don't have too much of medication, but the best would be nutraceuticals, good quality nutraceuticals, and good glucose control. Good evening to Dr. Anshul Singh from Chhattisgarh. Yes, you are right, Dr. Anshul. So, hypoglycemia is actually related to long duration of diabetes and age. So, thanks for pointing that out. And thanks to Dr. Siddharth Dhangar also for joining us. We have these comments, I think, from last week also, and the week before that, that the screen is hazy. So, Vinay, let me ask our backend to check about that, because the screens I see are fine, but we will check about it and get back to you in case there's an issue. So, this is for our backend team to work on, and thanks for pointing this out. Dr. Miramis has a patient who is on Mixtard twice a day, perhaps. Okay, saroglitazar was added. Yes, it can cause hypo. That's true. So we can reduce the dose of Mixtard. Probably saroglitazar was added for fatty liver, and we'll continue that prescription. But we can reduce the dose of Mixtard. You are right, that does happen. Hypoglycemia awareness, Dr. Singhani says, how do we treat? So first of all, we try to prevent hypo. Use small, frequent doses of insulin. If the patient has severe autonomic neuropathy, that's hypoglycemia unawareness, patient will have other complications as well. So avoid sulfonylureas at all cost. At all cost, try to avoid oral drugs as well. Use insulin. Use insulin analogs. Small frequent meals. Use the safest analogs that are available. So in the prandial state, you have ultra rapid acting prandial insulins. We have two. One is 5-ASP, that is fast acting insulin aspart. The brand name is Novorapid. The other one is early, URLI, that is ultra rapid acting Lispro. The brand name is Limjev, LYMJEV. Both can be given up to 15 minutes after a meal. So maybe in the average patient with hypoglycemia unawareness, I'll say, sir, let's give you 4 injections of insulin a day, maybe 4 or 5 units of 5-ASP or early after each meal, not before. And the basal insulin should be an ultra long acting with minimal hypoglycemia. So there, the choice would be Degludec or Glagine U300, which cause less hypo. We can also use Detemir once or twice a day. That also is associated with less hypoglycemia. Keep the patient on lower doses. If the glucose rises, increase very slowly by 1 or 1.5 or 2 units. Don't increase suddenly. And add nutraceuticals. Teach the patient about sympathetic and parasympathetic signs, symptoms. Let the patient understand his or her own body. And usually in around 6 weeks, the patient will come out. Dr. Bharat Praveen shares a challenging case, newly detected type 2 diabetes. After glucose control, yes, they feel symptoms. So we reduce the dose. We tell them, thank you for having taken the medication. Now your glucose levels are coming down. You are getting neuroglycopenia. Patient will say, sir, my glucose is 150, but still I have hypo. So my answer is yes, thank you for having been so observant. Your blood glucose may be 150, but if there were a system, if you could check your brain glucose, that would be 100. Now we all know that CSF glucose is less than uh, plasma glucose. So what I'm telling is the truth. It is a scientific statement. But your brain glucose is down, so let's reduce the dose and see what happens. You can reduce the dose of sulfonylurea in such cases. Keep metformin, DPP4 inhibitor, SGLT2 inhibitor the same. If symptoms don't respond to that, then another reason may be we tell the patient instead of low glucose, you may be having low salt. Maybe we are giving too much of diuretic, or maybe patient is not eating enough salt. So just make sure that the diet is well managed and diuretic dose may be reduced. A very tough question from Dr. Raisinghani, that is, which yoga improves autonomic function? So please allow me to take help of Dr. Anshul Singhai. He is from Bhilai in Chhattisgarh and he is logged in, I hope. Dr. Anshul is an expert in yoga as well. Uh, in general, while we wait for Dr. Anshul to help me out, so har ek friend zaruri hota hai, and even in the quizzes that we have on TV, even there you are allowed to phone a friend. So while we wait for Dr. Anshul to help us out, uh, all the yoga postures actually help in improving autonomic function. If you have a yoga, not a yoga, if you have a sports which makes you run very fast, which makes you hyperventilate, that is hypersympathetic. If you have a yoga posture which makes you relax, or a sports which makes you run slowly, like a marathon, slow running, slow walking, that will improve parasympathetic tone. We already mentioned that in diabetes, it is parasympathetic tone which is uh, impaired, first of all. So, mostly our aim is to improve parasympathetic tone. That will be done by the relaxing yoga mudras. Also, at that, so you encourage parasympathetic tone. Also, at the same time, you make your patient understand the sympathetic symptoms that are going on in his or her body. Someone may say anger, someone may say irritability, others may say mm, uneasiness, unexplained fear of something. So, this verbiage we should understand, local verbiage will change. Also, the stimuli which precipitate hypersympathetic activity, like maybe caffeine, alcohol, horror films, loud music, running very fast, these should be minimized as well. Dr. Deepak says some people come with A1C. Yeah, okay. So if patient is doing very well, we can continue. Now, ideally, A1C should be below 7, but if you can keep it below 6.5, that is better. If the patient doesn't have hypo, then we should continue. SGLT2 inhibitors, especially, are given not only for glucose lowering but also for vascular protection. So those we should continue. If patient says there is discomfort, I may reduce the dose of metformin. Now, this was Dr. Deepak's question. But supposing Dr. Deepak says A1C is 5.6 and patient is on sulfonylurea, then I will certainly reduce because we want to avoid hypoglycemia at all costs. Remember also for pregnancy, the target HbA1c is less than 6. 7 is, it's like Jugaad, it's okay. But ideally, all women in pregnancy should have an A1C less than 6. And all adults try for 6.5, but if you can't manage, 7 is okay, even 8 should be fine. But try to keep it below 7 or 6.5. Dr. Anshul has helped us out. Thank you. So he suggests two yoga procedures. One is Yoga Nidra, Yog Nidra, and the other is Pranayam, which help in addressing diabetes distress related to autonomic neuropathy. So thank you, Dr. Anshul, for that. Actually, we should work together to create a hypoglycemia awareness tool which is able to integrate yoga. And if we can do that together, I think that will help our patients more. So today our topic was hypoglycemia awareness training. We have all learned more about hypo. We have learned about the fact that we can train our patients, and in fact now many of us are realizing, yes, I myself become hypersympathetic at times. At other times I am hyper parasympathetic. So if I can work on myself, try to ensure autonomic balance, autonomic hygiene, I will be able to become a better person, a healthier person, and then I can help my patients also become healthier. One verbiage we get is from Agarwal Sahab, who is 80 years old, who says that, okay, the H1C is 8, there is cellulitis and edema as well. So, amlodipine, yes, amlodipine we should stop. So, Senior Agarwal Sahab says that I feel that water is flowing in the nerve. We must stop amlodipine. That will cause water retention. If you wish to stick to a calcium channel blocker, then cilnidipine is better. But if the urea, creatinine, and potassium are okay, it would be a good idea to start an ACE inhibitor or ARB instead of the calcium channel blocker. In some people, we say you add an ACE inhibitor ARB. Here for Senior Agarwal Sahab, because he's 80, it would be better that we interchange to an ACE inhibitor ARB. If BP rises, we can always increase the dose or we can add a diuretic. But for the time being, we should shift from one drug to another drug. That should be interchange. And the cellulitis, of course, will resolve with antibiotics. Uh, Another tough question for Dr. Deepak. Sweets once in a while, yes. So if my patient is maintaining good HbA1c and my patient raises the question, then I'll say the best Indian sweet for you is rasmalai or rasgulla. Rasmalai rasgulla is boiled or baked milk. So if you are able to squeeze the rasgulla or rasmalai properly, but sache dil se squeeze karna hai, then you are basically eating milk instead of drinking it. So that's the first choice. Second choice would be barfi, अच्छे से भुनी हुई, well baked barfi. So अच्छे से भुनी हुई बर्फी, if they take half a piece of kaju barfi or badam barfi, that won't do too much of harm. What we do strongly encourage is the fried mithais, the fried sweetmeats, which will include virtually everything else apart from barfi and apart from rasgulla rasmalai. All the rest would be gulab jamun, balushai, um, all the tasty things actually, pinnis and laddus and panjiris. So these have a lot of ghee, and we should try to reduce them. We should try to avoid them at all costs. We encourage take of fruits. So, like I'll tell my patients, say if you eat one banana, you will eat it within 30 seconds. Tripti nahi aati, the enjoyment is not there. If you cut that banana into 10 parts, eat it one by one, eat each part one by one, you extend that eating to 1.5 minutes. Enjoyment is more. You cut it into 10 parts and take each part with the tiniest fork that you have. That will be 3 minutes, more enjoyment. And those same 10 parts you put in raita, not in cream. So don't take fruit cream, but you can take fruit raita actually. And that also will take 4 5 minutes to finish and you will enjoy it. Don't put extra sugar or salt in the raita. Dr. Anshul says, yeah, autonomic neuropathy remains irreversible and remains undiagnosed. And patients have to go to specialists for gastroparesis and bladder dysfunction. As you keep on working in your community, Dr. Anshul, these patients will come down mercifully. And the moment you have bladder dysfunction, that is a sign of very poor prognosis, actually, that we have seen in practice. Sometimes we lose these patients. So it's a good idea to have shared responsibility. Ask the patient to consult other specialists, especially type 1 girls or type 1 men or elderly people with bladder dysfunction. But as you keep on working in your community, patients will come earlier and earlier, and this irreversible AN will reduce in your practice. You will have more patients with temporary or reversible autonomic neuropathy. Weight improvement for diabetic patients. Many patients, yes, they want weight gain because they say kaam nahi chalta. So in my OPD, a policeman, a traffic policeman, a sarpanch who has been recently elected, their chief complaint is I want to gain weight. So insulin, of course, is one thing. We add calcium, vitamin D. You can add pioglitazone if you wish. And sometimes we add medical nutrition therapy. So we give them protein supplements. And Dr. Anshul says, yes, the risk of sudden death is very high in cardiac autonomic neuropathy, so we need to be aware. Tell your patient to learn these symptoms, and it's safer for you as well as for the patient. And like I said already, anybody with especially urologic autonomic neuropathy, even cardiac, is a good idea to distribute the risk. So engage a fellow colleague also in the management. Welcome to Dr. Shashi Khare as well. Millets, okay, Dr. Maheshi, that's a good question. Yeah, they sort of patients ask about millets. So millets are carbohydrates. They will be a replacement for cereals, not an add-on. So if they say I'm taking millets, we say fine, go ahead, but do check your glucose. Don't add millets to whatever carbohydrate you are taking, and try to take different cereals or different millets at different times. The main issue we have is with not with millets, but with चने का आटा versus besan. So, chana is gram, chane ka atta is gram flour, besan is also gram flour. But besan is dehusked. It's yellow color. There is no fiber in it, and that increases glucose a lot. If your patient is able to take gram flour, which has not been husked, that will be beneficial for the patient. And thanks, Dr. Anshul, for your kind words. From Dr. Hilal, we get a tough question. OHA that is best for compensated cirrhosis. Okay, so you can give metformin in low dose, you can give linagliptin, and you can also give sulfonylurea in low dose. The safest one would be glyclazide. Thank you, Dr. VK Goel, sir, for being with us. The recordings are always available online. And thank you, Dr. Arpan. So, like we said, stop the amlodipine and shift to maybe perindopril or to telmisartan. Just keep an eye on the renal functions. And also, if BP doesn't fall with only ACE inhibitor or ARB, then you can add a diuretic. The safest one at age 80 would be indapamide. Good evening to Dr. Dheeraj and Dr. Kailash Garg as well. Barley water is a good idea, Dr. VK Goel. Yeah, it's a nice way. Only contraindications I can think of are two right now. First of all, patient with celiac disease, they should avoid wheat as well as barley. So celiac disease avoid. Second, patients who are on thyroxine. So if your patient is taking thyroxine and half an hour or 1 hour before or after that they take barley water, the absorption may come down. We don't have data on that, but in my OPD, I see that the commonest reasons for increase in TSH, even though the patient is taking proper therapy, are they suddenly start to take fenugreek water or fenugreek seeds or barley water in the morning, or maybe any other kind of desi medication, and that reduces the absorption of thyroxine. So right now I can think of only two contraindications for barley water. One is celiac disease. One is don't take it a few hours before or after thyroxine. Dapagliflozin can be used in chronic liver disease, Dr. Wage, in mild or moderate chronic liver disease. In general, if your patient is stable, then we can give SGLT2 inhibitor. If your patient is unstable means patient is admitted in hospital or is coming repeatedly with infections, then good idea not to give. Metformin 1000 patient will not be able to tolerate in chronic liver disease. If you wish to give, you give 500 BD or 250 TDS and then see what happens. But don't give 1000 at one time. Most chronic liver disease patients will not be able to tolerate that. Also, if at all there is going to be any electrolyte disturbance, that will not be because of dapagliflozin. It will be because of other diuretics. If your patient is already on high dose spironolactone, that can cause hyperkalemia, not dapa. Barley water will be good from a satiety point of view. It won't impact the kidney. In fact, in patients with chronic kidney disease, stage 4 5, where you want to restrict fluids, adding extra water will be a burden on the patient's physiology. Ivabradine, yes, Dr. Dheeraj, I do use actually. So, ivabradine and beta blocker both can be used to reduce heart rate in diabetic autonomic neuropathy with tachycardia. The checklist for side effects for contraindications of beta blocker is a bit longer. For ivabradine, it's shorter. So actually, I do use it, and patients are happy on 2.5 milligram or 5 milligram. I also use bisoprolol. So you can use both, but don't use both together. But you can try in different patients. If your patient is hyper anxious, an anxious personality, anxious temperament, then the beta blocker will be better. If there's not too much of anxiety, but tachycardia is there, then ivabradine is good drug to use. So try that. Barley water, I personally do not advise to my patients, and beer also I don't advise, Dr. Vicky will. But we can always try and see. Beer will increase glucose like anything. So out of all the alcoholic drinks, beer increases glucose the most. Barley water, you can advise for satiety. So patient might wish to take a glass or two of barley water before the meal to improve satiety and reduce hunger. Okay, so Dr. Wage suggests she has a tough case, 60-year-old lady, 4 injections a day, that's fine, and metformin plus DAPA and rosuvastatin and saroglitazar and Carca 3.125. What I would do, I would look for the renal function as well, make sure that the EGFR is above 30. Secondly, maybe I would change the metformin to 500 milligram twice a day. But otherwise, you seem to be doing the best already. So thank you, Dr. Hilal, for sharing this patient. When you make metformin 500 milligram BD, that actually helps the patient. The size of the tablet goes down, so it makes it easier to swallow. Secondly, the tablet that we are giving at night, that helps in bringing down the fasting glucose as well. If there is hypoglycemia, the culprit here will be the NPH, and we can shift to an analog like glargine or degludec. Dr. Miramis asks about metabolic side effects. Very rare. Hypokalemia will not occur because of DAPA. Very rarely. Hyper will not occur at all. Acidosis, yes. Metabolic acidosis, euglycemic acidosis can occur. So there you have to check the urine ketones. Ketones will be positive. Sugar always will be positive in the urine with DAPA, but if ketones are positive, we should stop. You can give it the diuretics with thiazides easily. With loop diuretics, reduce the dose to half. If, however, patient complains of giddiness with or without postural hypotension, sometimes we stop the drug. So, Dr. Mees, if you allow me to speak in Hindi, what I ask my patients is, ऐसा लगता है क्या कि नींबू निचोड़ दिया है किसी ने आपका? Do you feel that someone has squeezed you like they squeeze a lemon? If the answer is yes, then I stop the SGLT2 inhibitor and patient improves. the guidelines tell us to give SGLT2 inhibitor to everybody, but the guidelines do not tell us not to take a history. So if your patient is uncomfortable, feeling sick or lazy, like I said, the lemon has been squeezed out of the patient's life, just stop DAPA and see what happens. Do not start DAPA and loop diuretic together on the same day. So that I think would be an absolute no. We should avoid that. So with this, thank you, Dr. Hilal, for your kind words and for being with us. And do let us know how the patient responds to your therapy. With this, I'd like to thank everyone for having been with us today. For me, it's always a pleasure being part of this, and I learn so much from these talks. All the questions are so challenging, and together, I'm sure. Okay, for this patient, linagliptin would be better, Dr. Wage. Yeah. So linagliptin would be better, and I'd like to. Linagliptin would be safer. Linagliptin would certainly be safer in this patient. DAPA will help in long-term cardiovascular outcomes. So if your patient is stable, there's no issue at all, no immediate issue. And now you say, okay, let's do something better for you. Let's look at long-term outcomes. Then we add DAPA. If it's just glucose control that we are worried about, and there are always some symptoms or the other going on. Every month the patient is in your OPD with different symptoms. Then linagliptin would be safer. Thank you to Dr. Mahesh and Dr. Anshul as well. It's always fun chatting with you. And thank you, Anshul, for helping us out with the yoga, with the pranayam and yoga nidra. It's time for nidra as well. It's time for dinner too for many of us. So I'd like to welcome Team FDC back onto the stage. Thank you, Team FDC, for doing all that you do for us.
Thank you so much, Dr. Sanjay Karla sir, for share your expertise, your experience in clinic experiences about hypoglycemia. And I would also like to thank all the attendees, doctors who took their time on weekend and join us. And in next weekend we will back with new topic and new energy. Till then, Jai Hind. Good night.
Jai Hind.